Hello and welcome to the Drexel interview. I'm your host, Paula Morantz-Cohen, and today our guest is Dr. John A. Rich, Chairman of the Department of Health Management and Policy at Drexel University's School of Public Health. Dr. Rich is the winner of a 2006 MacArthur Fellowship for his work on the healthcare needs of young men in the inner city. Dr. Rich, welcome to the Drexel interview.
Thank you. It's my pleasure to be here.
Well, I want to start by explaining that the MacArthur Fellowship is a special grant given to researchers, writers, and others who do important work for society and culture. It's sometimes called a Genius Award, and it's a great honor. And congratulations again, John, for receiving it.
Thank you.
I want to start by welcoming you to Drexel. I know you came here in 2005, and before that, you worked at the Young Men's Health Clinic in Boston. You started there in 1993, and that's where you began an important project. And I wonder if you talk a little bit about that project and what happened there before we move into what your plans are here in Philadelphia.
Sure. Well, in 1989, I went to Boston City Hospital to be a primary care doctor. And after being there for maybe a couple of years, I noticed that young men weren't seen in primary care. That as I walked through the primary care center at the hospital, I'd see them in the orthopedic clinic, or I'd see them in dermatology, or the sexually transmitted disease clinic, or emergency department. But I didn't see them in primary care, and it didn't really make sense to me. And it turned out, I think, that primary care wasn't well suited to their needs. And so we began a clinic called the Young Men's Health Clinic at that time. And the idea was to say, could we help bridge the gap between pediatric and adolescent care and adult care? Because it's very clear that men tend to fall out of the healthcare system when they reach about 18.
Right.
And what we really did was to try and say, what are the needs that these young men have? But more importantly, how can we use the clinic as a door to the other services that they need? Because we knew that many of their needs were employment, education, that there were issues of mental health and trauma. And so it was an opportunity to use healthcare, which they were using anyway. They just weren't using it in primary care, to try and deal with the preventive health needs, but also connect them with other important community resources.
Now, when you say they weren't using primary care and you weren't seeing them in the primary care unit, I mean, what is the significance of that? Well, you said they were using the healthcare system, but what was it that they should have been doing that they weren't, and why?
Well, what we know is that in pediatric care, it's about 50-50 girls, boys. In adolescent care, it's about 75% girls. And so what you're seeing is young men who exit the healthcare system except when they have an episodic need. So if they sprain a shoulder, or if they get an infection, or if they get a skin rash, they seek health care in that way. Now, the reason for that is partly that it's hard for them to get insurance.
Yeah.
And so they're only interacting with the healthcare system on an episodic basis. But the healthcare system, I think, was failing them because in some ways we were accepting that. We were saying we know that these young men are at risk for chronic diseases like the things that are related to smoking or lack of exercise, so heart disease or cancer. And so what we were seeing in primary care is men in their mid-40s coming into care when they had 20 years of hypertension, 20 years of smoking. And so our job was to say, could we bridge this gap in a preventive way that would enhance the health of this community? Because we actually know that African American men, in particular, have the worst health status of any group when you look across the diseases that are chronic. And so we really have to get an early start if we're going to prevent those kinds of diseases.
Okay, well, you say that you identified this problem and then you went about doing some in-depth interviews with young inner-city men. Could you tell us about that? Was that what made you realize that you need to fill this need? And then tell us a little bit about what you did about it.
In a sense, these were parallel tracks. While I was concerned about primary care for young men, at the time, in the early 90s, we were in the midst of the worst epidemic of violence, really across the country, but certainly for Boston. And so in addition to not seeing these young men in primary care, when I did see them, often they had scars. They were recovering from violent injury. And one day I was actually walking through the hospital, and I ran into a colleague of mine who's both an internist and a trauma surgeon, also an African-American man. And he said to me, you know, we're seeing all these young guys come in. They've been shot or stabbed. And I'm a trauma surgeon, so I sew them up. And then a few weeks later, I'm driving in my car, and I hear on the radio that the same young man is dead. He said, you know, they come in, they don't do anything. They sit in the beds after they come out of surgery. And I got the idea at that time that we should try and learn something about why it was that young men were coming in with injuries and then coming back. And so because I was learning a little bit about narrative and qualitative research, and I had some great mentors, I got a tape recorder, and I started to, you know, I did all of the important things like human subjects approval and designed an open-ended interview schedule. But then when I began to talk to these young men and analyze carefully what it was that they were saying about their lives, and it was really eye-opening to me.
So you started out with this interest in primary care, and then you moved into this interest in how violence affected the lives of these young men. And so that was sort of a shift. I mean, that's much more dramatic than issues of, I mean, stress and obesity and diabetes and those sorts of things. Now we're dealing with gunshot wounds and the kind of trauma that would cause. Did you find that you had to rethink a lot of the ways you had been thinking about patients and so forth when you began thinking about violence and this population?
You know, oddly enough, not really. There really is a continuum that many of these young men who, when you see them in primary care, violence has been a part of their lives. They've experienced trauma because, excuse me, they've lost friends to trauma. They may have seen violence in their communities. And so there really is a continuum. We can't actually separate those who have been injured from those who need primary care. But interestingly, along the way, that was a common theme. So people would say, from the time that we started the clinic, we called it the Young Men's Health Clinic. But frequently, colleagues would say, how's that violence prevention clinic you started? I'd say, no, it's not a violence prevention clinic. It really is primary care for young men who are at higher risk of violence than other groups. But there's a continuum about seeing these young men as whole, trying to envision them as whole, and when they've been injured, trying to help them regain that sense of wholeness.
So I imagine that psychiatry or psychology was a big element in the treatment. How did you deal with that, or how does that come into play with the care for the physical needs of this population?
Well, it's a good question. Much of primary care is, in fact, psychiatry or psychology. So we say 40% of what we do in primary care deals with mental health. And so in viewing this kind of holistic view of these young men, we were trying to envision the body and the mind as connected. And that's where trauma is a good organizing framework, because we know that trauma has an effect on the mind, but that is also an effect on the physical body. So that it wasn't so hard to see those things as together. Now, one of the critical needs that you can meet when you're dealing with these young men is to normalize their symptoms. Because if they come in and they've been victims of violence, when they go out, many of them experience nightmares, flashbacks. They can be incredibly numb to their community. The places that they used to go that they felt afraid, they don't feel afraid anymore. Or loving feelings that they had towards family or friends will suddenly disappear. But they don't actually know that's normal. That's what happens in the aftermath of trauma. And so sent back out into communities where there are a lot of guns and there's a lot of danger, they're really twitchy. And they might actually start to do things in an effort to protect themselves that would put them at greater risk. So, for example, if someone shot you and you feel in great danger because you're having these symptoms and you don't know that they're normal, you might get a weapon. And so our understanding of this...
So it becomes cyclical.
It becomes cyclical as a response to something that is normal than anyone would experience. Although in the social context that they're feeling it, it has much more dire consequences if they take those actions.
I could see that. I also wonder, though, if you found that you got resistance from this population when the mental health element was introduced, in the sense that, I mean, I suppose part of the reason that these young men don't seek primary care is perhaps a sense that it's a sign of weakness to consult a physician, and perhaps also the sense that it's embarrassing, and that they don't get the respect from the system that they feel they should. But I would imagine that if they're being told that they need to deal with mental problems, that might scare them further. How did you deal with that?
Well, I think that for men, I think generally for men in our culture and our society, seeking health care is seen as weak. And that's something that we've sort of propagated over time. Real boys don't cry, or big boys don't cry. Now, in this setting, I don't know that we typically would say to a young person, you have a mental health problem. But young people in the inner city understand stress, and they understand grief, and they understand loss. And so couching it in these terms, but making also the analogy to, for example, soldiers in an armed combat.
Right.
That's an identification that they can understand. And surprisingly, these symptoms are very close to the surface. But when these young men often enter the healthcare system, they're treated in such an aggressive way, or they're treated in such a stereotypical way, that there's not an opening left for it to come out. So it's not uncommon for young men to report that providers would say to them, you need to change your lifestyle, before ever having heard anything about their lifestyles. And so that it goes a long way to say to someone, this is terrible, you got shot, that's got to be hard. You must be in a lot of pain, both physically and emotionally. That's easy for us, and that's a tool that we use as physicians all the time, to use empathy. But often physicians are from such a different place than these patients. It can be difficult to mobilize empathy and to say, yeah, I kind of know what it would be like to go through this. But talking to these young men gave me a better sense, even though I personally have never been violently injured, I got a better sense of what it would be like, and what you would go through, and how you would try and make sense of this for the rest of your life.
Was it upsetting for you to be in this environment, hearing these stories, I guess, on a regular basis? Did you find that hard to deal with?
I didn't find it as hard to deal with as I thought I might initially. The reason is that the stories are much more textured and full than the stories we read in the paper all the time. That is, these are young people who have families, who have children, who have things that they care about. And they are resilient in a way that I wouldn't have known. So a lot of the young men actually write rhymes or raps. And in that form, they can put a lot of their pain, a lot of their anxiety, and they would actually sometimes perform them in the interview. And so it was really, there is a process of seeing these young men as whole that you don't get if you only see them lying in the bed, or you only see them when they come into the emergency room. Okay.
Well, you left Boston for Philadelphia. Would you say that clinic, I assume, is still operating successfully, would you say?
It is.
And you are now in the process of doing something similar in Philadelphia. Could you tell us a little bit about what you're doing here?
Well, as someone who's relatively new to Philadelphia, and as someone who really transitioned here not for the purpose of establishing a clinic or the same work, but really for personal and professional reasons, I'm really learning a lot about Philadelphia. And you can't necessarily take an idea like the Young Men's Health Clinic or the work that we were doing in Boston and transplant it. Because
why not?
Well,
that's
because
interesting.
I think that there are a couple of things. One is you have to know the communities that you're working with, and you have to establish some trust to understand the best place to do it.
Yeah.
Second, Massachusetts happens to have a very generous insurance program for the uninsured, essentially insurance. That is, it's called the free care pool. And so taking care of these patients was not a problem for the hospital because the